How are you, Dr. Omar?
Okay, can you hear me?
Yes, we can hear you. We will give a lecture about bridging the gap between neurosurgery and neuroophthalmology. Please,
Yes,
Dr. Omar.
thank you so much for having me. And I will speak about bridging the gap between neuroophthalmology and neurosurgery. So the outline of the speech will be firstly about what is neuroophthalmology and the scope of neuroophthalmology, then coming to the multidisciplinary approach and the importance of that in treating these cases, coming to cross-referrals between neuroophthalmology and neurosurgery, and neuroophthalmology evaluation, coming to some of the common case scenarios in neuroophthalmology clinic and the conclusion. So starting with a brief introduction about what is neuroophthalmology. So it is a subspecialty of both neurology and ophthalmology that focuses on disorders affecting the visual pathways, optic nerves, and connections between eyes and the brain. It delves into the diagnosis and management of conditions where neurological and ophthalmic issues intersect, making it a critical field in understanding the complexities of vision and its neurological underpinnings. So what is the scope of neuroophthalmology, what we are dealing with? Starting with the optic nerve disorders, with their evaluation and management of optic nerve disorders, starting from the optic neuropathies with the different etiologies, whether it is ischemic, toxic, nutritional, hereditary, and other types of optic neuropathies, coming to also optic atrophy and optic neuritis. Coming to the visual pathway lesions, diagnosis and treatment of lesions affecting the visual pathways, and pupillary abnormalities, assessment of the abnormalities in pupil function and response, and coming to the visual field abnormalities, whether it is glaucomatous visual field abnormality or neurological visual field abnormality, and how to localize the lesion according to the visual field effect, whether it is congruous or incongruous, whether it is homonymous or heteronymous, and coming to neurological causes of diplopia, whether it is due to cranial nerve pulses or due to some neuromuscular problems like myasthenia gravis. So coming to the importance of multidisciplinary approach when we are dealing with patients with neuroophthalmic problems, whether it is cranial nerve pulses, whether it is other neurological disorders that is also affecting optic nerve and visual pathways. So it is really very important to have more collaboration and more cooperation, and to have more effective and timely referral between these two specialties, so the patients will be diagnosed early and also will be managed early and promptly. So cross-referrals between neurosurgery and neuroophthalmology. I will talk about some of the examples of the cases that usually will be referred from and to neuroophthalmology. So these are some of the cases that usually will be referred, like papilledema cases. So those patients might start with the neuroophthalmology clinic. They will come with complaints of headache, tinnitus, transient visual obscurations, nausea and vomiting. Also patients with optic neuropathies, whether it is toxic optic neuropathy, whether it is other etiologies of optic neuropathy, usually they will come with whether decreased vision or central scotomas or visual field defects. Coming to cranial nerve pulses and optic nerve glioma, that is one of the cases that usually will come with sudden vision loss or with proptosis. Acquired nystagmus also, like opsoclonus, and pituitary tumors like pituitary adenomas and other cellular and supracellular tumors and masses. Come to head traumas and visual confusion. These are just few examples of the cases that neuroophthalmology clinic will deal with, and also neurosurgery clinic. Coming to the neuroophthalmological evaluation, so history taking is the most important tool, and one of the most eminent neuroophthalmologists, Dr. Walsh Hoyt, said that 90% of clinical neuroophthalmology is in the taking of the history. So only with taking proper history, you can having a very narrow differential diagnosis, and with examination and few ancillary tests, you can confirm this diagnosis. So examination of neuroophthalmology usually start with general examination, examination of head and neck, then examination of orbits, whether there is any proptosis or dystopia, eyelids, whether there is any ptosis or lid retraction, and pupils, if there is any RAPD, APD, anisocoria, and examination of vision. And it's not only the visual acuity, but also it comprises the contrast sensitivity, color vision, and visual field, confrontation visual field, before going to the automated perimetry. Examination of the eye, of course, anterior segment and posterior segment, then examination of eye movements, motility, to check if there is any limitation of the motility, if there is any affection of the third, fourth, or sixth cranial nerve. Coming to the assessment of higher visual function. So coming to 4 common case scenarios I will present today in this talk, starting with pituitary adenoma causing compression of the optic chiasm, which one of the very common cases in your ophthalmology clinic. So this is a case of 43-year-old female with painless progressive vision loss. Chief complaint was painless central vision loss in the left eye. History of present illness, presented with painless central vision loss in the left eye. Recently, she had noted difficulty with reading and opaque white light in her central vision of the left eye, scotoma. Past ocular history was negative, and past medical history, she has hypothyroidism and she is on levothyroxine. Family history was negative also, and systemic review was none. Nothing was significant to the case. Coming to the ocular examination, visual acuity was 6.9 in the right eye and 6.36 in the left eye with eccentric fixation. Intraocular pressure was normal. Pupils, there was relative afferent pupillary defect in the left eye, OS. And confrontation visual field reveals temporal loss in the right eye and central scotoma in the left eye. Anterior segment was normal, and fundus shown temporal optic nerve pallor. So this is a picture showing temporal optic nerve pallor in both eyes. So we did brain MRI for this patient, and it revealed pituitary tumor. So after MRI revealed the suprasellar mass, patient was referred to neurosurgery, and endocrine laboratory testing was done to determine if it is a lactotrophic adenoma or it is non-secreting adenoma, and hormonal levels was normal. So the patient had macroadenoma, and he underwent transsphenoidal gross total resection of the tumor. Coming to the next case, it is a case of neurofibromatosis type 1 optic nerve glioma. So this is an 8-year-old female with acute complete vision loss. She had no pain, no photopsias, no floaters, no other symptoms. Patient has a known history of neurofibromatosis type 1 with prior radiologic documentation of CNS hamartomas, and also documented skin findings consistent with neurofibromatosis type 1. Medications, she is not taking any medications. Family history, positive for neurofibromatosis. Coming to the examination, generally she was well appearing and skin multiple cafe au lait spots on back and axillae. Visual acuity was 6.9 in the right eye and no light perception in the left eye. Extraocular motility, slightly impaired up gaze in the left eye. And pupils, there is afferent pupillary defect in the left eye. External and anterior segment examination, fewlish nodules on the iris in both eyes, and confrontation visual field in right eye was full. On the left, of course, because patient has no light perception, it was only a black field. Dilated fundus exam shown grade 3 papilledema with pallor in the left eye. So that is a picture showing pallid optic disc swelling. So the clinical course of the case, MRI was done of the head and orbit, and well circumscribed fusiform enlargement of the left optic nerve was revealed on MRI. And this is pictures of the MRI that was done with the fusiform tumor in the optic nerve of the left eye. Findings on MRI confirmed the suspicions of an optic nerve glioma. Also, the history helped us a lot because she is having neurofibromatosis type 1, and it is associated with optic nerve glioma. Patient already has no light perception and it's non-painful. So, and there is no intracranial extension. So the patient was only followed up in the clinic, and also serial imaging done to check if there is any intracranial extension. Coming to the third case, cranial nerve fourth palsy, trochlear nerve palsy. So this is a case of 57-year-old male complaining of vertical diplopia after head trauma. Patient has double vision, binocular vertical diplopia. He noticed diplopia immediately upon awakening after he fell down, and history of brief loss of consciousness post falling down. MRI was done and CT was done, and both did not show any abnormalities. Also, there was no orbital fractures. He described painless binocular vertical diplopia that worsened when he looked to the left, but improved when he tilted his head to the left. And he thought that the diplopia was worsened when he tried to read on the down gaze. Post-ocular history, he had done bilateral cataract surgery, and post-medical history was negative for the systemic problems. Medications, he's on aspirin, and family history was non-contributory. Review systems, it was negative for ptosis, anisocoria, dysphonia, dysphagia, dyspnea, fevers, vertigo, or imbalance, or headaches. Coming to examination of this patient, so visual acuity was normal, and pupils also normal. Coming to confrontation visual field, also it was full motility. There was mild to moderate infraduction deficit and supraduction excess in A deduction of OD, which is called, which is a sign of inferior oblique overaction and superior oblique underaction in the right eye. Alignment, patient had 30 prism diopter of right hypertropia that increased on the left gaze and increased on the right head tilt. 7 degrees of exciprotorsion on DMR. So slit lamp examination was okay. Fundus examination shown right eye extorsion. So diagnosis was traumatic right cranial nerve fourth palsy, and given the acute painless onset with normal neuroimaging it was labeled as traumatic fourth cranial nerve palsy. Patient was treated with occlusion therapy over his right eye to alleviate the diplopia. After that, he was followed up at 3 and 6 months. Later, diplopia persists and angle of deviation was stable, so strabismus surgery done to alleviate the diplopia. This is the picture of the patient before and after the strabismus surgery. Before, he had right hypertropia, and it was treated surgically to treat the deviation and also to alleviate the diplopia. So, coming to the last case, idiopathic intracranial hypertension. So, patient came with headaches and transient double vision for 6 months. It was 31-year-old female, and she was obese. History of present illness, as I mentioned, headaches and TVOs for 6 months. Also reported ringing sound in her ears, tinnitus for past year. Past ocular history was not significant. Past medical history, only the obesity and medications. She's not on any medications. Family history was non-contributory, and review systems was also non-contributory. Examination, visual acuity was 6.6 in both eyes. Extraocular motility was full, and pupils were normal. Color vision is normal in both eyes, and she had normal cranial nerve 5th and 7th function bilaterally. External and slit-lamp examination was normal. Coming to the fundus examination, she has grade 2 papilledema. So here we can see the picture of both optic nerves swollen with blurred disc margins and mild hyperemia. Course of the case, patient was given acetazolamide. Of course, after doing the neuroimaging, and also after normal neuroimaging, and also after doing the lumbar puncture, and CSF pressure was elevated. After that, she was given acetazolamide and she lost weight. Papilledema regresses, and also Diamox was tapered off without further complication. Yeah, so usually treatment of idiopathic intracranial hypertension, weight loss with sodium reduction and acetazolamide, discontinuation of causative medication if the patient is on any of the causative medication, whether steroids, nicotinic acid, or other medications that may exacerbate or cause idiopathic intracranial hypertension. So that is the general guidelines of the treatment. So coming to the conclusion, collaboration between neurosurgeons and neuroophthalmologists is crucial for managing the patients optimally. Thank you.